Wonderful. Okay, well, welcome everyone. Thank you for being here today. Um, I would like to first begin by recognizing and acknowledging that McMaster University is located on the traditional territories of the Mississauga and the Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. Today, we're here to discuss the challenges and inequities within women's health, and it got me thinking about the lives of the Indigenous women. The women of these nations played an integral role in the success of their communities. They were seen as both spiritual and governing leaders and were at the center of society. The women knew this land, they used this land, and they relied on this land to nourish, shelter, and heal the people of their communities. Colonization dramatically affected Indigenous women by displacing them from this land, stripping them of their status, taking their children, and all but erasing their matrilineal system with the introduction of patriarchy. The Dish with One Spoon Wampum Agreement reminds us to always show respect to Indigenous peoples and their enduring connection with their traditional territories and its histories, to acknowledge the harm done by colonization, and to continue to work towards reconciliation. And today we specifically honor Indigenous women for their incredible leadership, knowledge, courage, and strength. So just a few notes for today's session. The session is being recorded. All participants, as you can see, have their videos and their audios turned off. We will have a question session at the end, and questions can be posted within the Q&A only, as the chat function is also disabled. So please keep notes of your questions, and you can put them into the Q&A at the end. I would like to thank Dr. Lisa Schwartz and Kendra Wegscheidler for organizing today's event, which is designed to recognize the National Day of Remembrance and Action on Violence Against Women, which is observed on December 6th to commemorate the 1989 Montreal Massacre, where 14 women were murdered at the École Polytechnique in Montreal by a man who targeted the women for their gender. Each year, we honor their memory and raise awareness about gender-based violence. The Faculty of Engineering is hosting a commemorative event in recognition of this day, followed by a memorial walk around campus. This QR code that is showing on the slide can be used to register for the event. In addition, December 1st and 2nd, you're invited to attend the pop-up booth in the Thode Library for resources on gender-based violence, information about the National Day of Remembrance and Action on Violence Against Women, and more. Today's topic is a heavy one, and we encourage anyone who needs support after this panel to seek assistance. There are several resources on campus, which we've listed a few here. If you or anyone you know has experienced violence or the threat of violence, please seek help immediately by calling emergency services or accessing your local women's centers and programs. I'd like to introduce you to today's moderator, who is Dr. Roussanne Latif. She's McMaster's newly appointed Associate Director of the Sexual Violence Prevention and Response Office. Roussanne has more than a decade of experience as a researcher and clinician specializing in sexual violence. Her clinical work has included supporting survivors of sexual violence in an Indigenous health center, as well as working with individuals in correctional and forensic mental health settings. She also serves on the International Survivor-Centered Advisory Committee with the Exodus Road, a global nonprofit combating human trafficking. We're very excited to introduce you today to our panel of experts. So Sabrina Kyoto is a PhD candidate in epidemiology at the University of Toronto, whose research explores how structural and gender-based inequities influence maternal and perinatal health. She develops population-level prediction models to better understand and prevent adverse pregnancy outcomes and aims to translate this work into policies that promote equity and safety for women in healthcare settings. Dr. Crystal Garvey is an experienced nurse with over 2 decades of practice in emergency mental health nursing. She also serves as an adjunct professor in a collaborative Bachelor of Nursing program in the GTA. Her scholarship advances equitable, inclusive, and culturally responsive care with research focused on anti-bullying, mental health, theory development, and access to care. She has secured over $500,000 in grants addressing mental health and anti-racism, including a major CIHR CCSIF project supporting culturally responsive care for Black communities. Dr. Garvey also contributes to social justice initiatives, including work with an unaffiliated organization, and is the executive producer of Silent Voices, an award-winning documentary exploring mental health through the Black lens. Jacqueline Hay is a clinical exercise physiologist and PhD candidate in applied health sciences at the University of Manitoba. Her research addresses inequities in cardiac rehabilitation, participation, and advances risk and physical activity assessment strategies for people living or at risk of cardiovascular disease. She's a member of the Canadian Women's Heart Health Alliance and serves on two Canadian Societies for Exercise Physiology committees, advocating for inclusive, evidence-based, sex and gender-informed cardiovascular care. Thank you everyone for being here today. We're very excited to get started, so I'm going to pass this now on to Rusan, who will start the panel.
Hey, thank you. So welcome again to our incredible speakers. I'm really happy to be here with you all today and moderate this panel. I'm eager to hear what you all have to say so we can move right into our conversation. I'll invite our panelists to reflect on a few questions, starting with the following. Could each of you briefly introduce yourselves and share a bit about your work, particularly how your research or practice engages with current issues in women's health? So we'll start with whoever is ready to start.
I can start. Hi, everyone. Thank you so much for having me today. My name is Sabrina Kyoto. I'm a PhD epidemiology candidate at the University of Toronto. So, broadly, my work focuses on maternal and fetal health with a particular emphasis on predictive modeling and population health data, as well as population health policy. So, I'm really interested in how we can use large population based data to better identify who is at risk for complications during pregnancy and how we can intervene early enough to make a meaningful difference in someone's pregnancy journey. So, the main goal of my PhD dissertation is to develop a national population based prediction tool for adverse pregnancy outcomes. So, adverse pregnancy outcomes are things like preeclampsia, gestational diabetes, or placental complications. But I guess what makes my work a bit different is that I'm not only using clinical information. So I'm integrating clinical, but also social and environmental determinants of health using linked Canadian survey and hospital data. And I think kind of why I wanted to pursue, um, you know, this type of field for my dissertation is that a lot of perinatal epidemiology has really focused exclusively on clinical and biomedical factors, which are certainly important, but of course they only tell part of the story. And so there are currently major gaps in the field, including a limited integration of the social determinants of health. So things like socioeconomic marginalization, food insecurity, discrimination, and or access to stable housing, for example, despite clear evidence that these really do shape pregnancy risk long before someone even seeks perinatal care. And then there's also been a minimal incorporation of environmental exposures, which are becoming increasingly important in perinatal health due to things like climate change. And something else that I think is really important is that currently in Canada, there's really an underrepresentation of diverse populations in our data and our models, specifically for pregnancy research. And so my research is overall trying to fill those gaps and sort of building a tool that is truly population based and represents the lived realities of people across Canada. Thank you.
Thank you so much, Sabrina, for that holistic view of women's health and particularly in your research. So I'll pass it over to the next researcher. On my screen, it's okay. I was going to say it, Dr. Garvey.
Yes, thank you so much. Because I know I saw Jacqueline unmute her mic earlier, so I thought give her space to speak. So thank you for the opportunity to be here today. I'm very excited to have this very important conversation with all of you. A little bit about my research. So I'm in a two-pronged narrative right now. The first part of my research actually was looking at how mental health impacts or how bullying impacts the mental health of our students. And at this point, I've actually been able to formalize that theory or framework, where I'm now going to be publishing that in a nursing textbook, which will be released in the spring term. And this model that was created through the evidence-based lens, looking at the interrelatedness of power, of how various members of our community, especially architects of influence, which are our leaders, how they do impact the person or the community. So in this conversation, as we're talking about women and women's wellness, uh, you know, my framework takes the time to look at not only the women, but looking at the various intersectionalities that they may navigate, in addition to the various social determinants of health, but also look at the relationship between cultural values, belief systems, policies and laws that also could impact their lived experience, which then creates a biogenic or healthy environment for the women or the community of women to thrive, or create a bioacidic environment, which is unhealthy, or a toxic environment, which then will have a negative impact on that person or community, which is our population of women, may it be emotional, mental, physical, or spiritual. So that body of work is going to be coming out, and we're going to be looking at various case studies. One particular case study we do look at is of Adriana Smith, who was a woman, a nurse actually, who had a brain aneurysm, and as a consequence of her brain injury, she was on life support. And because of the laws in Atlanta, the doctors were uncertain, her fellow colleagues as well, were uncertain how to navigate this particular situation. So they kept her on life support while she was pregnant, and until it was safe for the institution then to have the baby through C-section. But she started to decay while she was on life support. So this was a major ethical issue that caused a major uproar within the community. In addition to that, I'm currently working on the CIHR grant in partnership with Ontario Shores. And even though that is a research project looking at how to bridge the gaps of with and for Black members of our community when accessing mental health care services, but also creating a culture responsive service. What the data is showing is that, especially with our Black women, is that we are accessing mental health services in a place of crisis. And so because we're accessing mental health services in a place of crisis, that also compounds the lived experience or the impact that it's having when having to access institution, such as their concerns being minimized or ignored, or they are being dismissed. And so, the touch points where they do access their family doctor or access their nurse practitioner, and they go with these concerns as, feeling stress, feeling anxiety, feeling overwhelmed because of just the day-to-day experience, it is, dismissed and looked as, oh, it's premenopause, or, oh, it's just because life is hard for everybody. But they're not realizing that as a Black woman, that we have to navigate a double-edged sword, and having to navigate the systemic barriers that we have to navigate anti-Black racism, in addition to then navigating the day-to-day experience as just being a woman. And so we are seeing this population accessing services when they're in a place of crises. And we're trying to determine, what are those touch points where we can support members of our Black community to access services before we get to that place. So thank you very much.
Oh, okay. I'll just transition myself. I just wanted to say I'm very excited to be here with two amazing speakers, and this topic and this women's health is very meaningful to me for multiple reasons. I'm actually a person with lived experience who faced violence in my academic setting, and basically had an injury to my hand that was a very rare injury that caused a whole bunch of challenges in seeking the diagnosis. Throughout all this process, I did not feel believed. I did not feel supported. I felt minimized. And this was really not the first time that I experienced misdiagnosis or someone I loved had faced a challenge in seeking a diagnosis. It's a bit of a running joke. In the last 12 years, after suffering only three significant injuries, all of which were underdiagnosed, I've actually undergone 15 different surgeries, of which only two I was able to receive without having to advocate for it. And this has really driven my passion towards thinking about sex, gender, intersectionality, position, race, socioeconomic status. And while I was going through all that at the same time, a lot of family stuff happened where my mom actually became diagnosed with heart disease. But again, that wasn't an easy path. Much of her experience actually echoed the Heart and Stroke Misunderstood report that demonstrates women are underaware, undersupported, and underdiagnosed when it comes to heart disease. So it's all these different experiences led me to kind of change my doctoral research to focus on how sex, our biology, and gender, how our roles, responsibilities, and interactions with healthcare affect our outcomes. So right now, I'm currently working with multiple collaborators, including the Canadian Women's Heart Health Alliance, people with lived or living experience, and within the healthcare system to try and increase awareness because so many of us still believe that we're more likely to suffer or have breast cancer than heart disease, and that's really not true. It's really important that I'm also working to improve risk prediction because all the different models and data were built using data from males, which again doesn't tell our story, lived experience, or understand how our roles, family, or all these things impact our how we even report our symptoms. The other thing I'm doing is trying to work within systems to understand how we can improve movement after surgery for cardiac rehabilitation because we know the sooner somebody moves, the better their outcomes are, and really to start understanding inequities in access and participation to cardiac rehabilitation. Because although we know it works, and there's studies in Alberta that showed if women go, they even have better outcomes than men, they often just don't go or take longer to go. So some of my research is looking at how can we measure that data, and then how can we do similar things that Sabrina was talking to improve our understanding of social determinants because our healthcare system doesn't have data that has that. So I'm using different linkages with the census to try and find a ways to answer that question. So looking forward to speaking more. Thanks.
Thank you so much, Jacqueline and Crystal, for both of your responses. I saw that you unmuted and I was eager to hear what you want to say, so I just let that be. But I think we're hearing a lot of how, in many ways, one size does not fit all, whether we're talking about who's represented in the research, and we're hearing a lot about how certain groups are excluded, whether that's women being excluded from research that was predominantly based on men, and how that's impacting their access and services. Or even when we look at different social identities, how different groups, particularly marginalized groups, have been excluded and how services aren't really responsive. And for that reason, likely that's impacting access as well and how willing people are to really engage with providers and service providers. Um, so I can continue on this conversation, but I will then ask my next question. Across your fields, what do you see as the most pressing structural or systemic barriers affecting women's health today? And how are your research or initiatives helping to address those barriers? So you've all certainly started to touch on this, and I'm really interested in hearing more. If it's helpful, also put the question in the chat to refer to. So whoever would like to start.
I'll go first. I kind of touched on it in the introduction, but when looking at the structural and systemic barriers impacting women, from the healthcare perspective, being a practitioner in the emergency room setting and the mental health setting, the first thing that the practitioners see is skin color. And so because that is the first thing they see, and because of the paradigm that has been entrenched into the learning experience through institution, through our historical narrative, and that has now that we're seeing the byproduct of that, meaning that when I, as a Black woman, attend or end up in the emergency room setting or end up in a healthcare setting, I'm not necessarily looked upon as a human. I'm looked upon as a specimen. And what I mean by that is that when you look at the history, like, when you think of Sims, who created the forceps, or you think about the history of the World Fair and the first anthropologist, William McGee and Alex Hitchler, who, created the pseudoscience to show that Black people were the missing link between humans and monkeys. That paradigm shifted into institution in literature and in textbooks.
Tell me what I have to
And
do.
because of that belief system, that has been entrenched into our social sciences, into the School of Medicine, into the schools of healthcare. It still seeps into the day-to-day practices in 2025. And the evidence is, again, I walk in, they see my skin color, and I'm treated differently. And it's not necessarily to say that the practitioner, and I want to preface this, that the practitioner is not racist, but it's something that's embedded into the subconscious. So some of the behaviors that we do see, and this is, evidence in the research, is that the behaviors are conscious or subconscious, and the outcome is the outcome. Is sometimes it's not the intent, but it's the impact that it does have. So, I have to preface all of that first before even talking about some of those systemic barriers that impact women. So as a byproduct of that, so now when I do have a concern going into my physician's office, my concerns are not taken seriously. I am othered. I am, Jacqueline touched on it. We're misdiagnosed all too frequently. I've had my firsthand lived experience of being misdiagnosed or mistreated or ignored, not only in the healthcare setting, but even in academia, where, I bring up a concern and my concern is not taken seriously. But if somebody that doesn't look like me say the same exact thing for verbatim, all of a sudden now it's logical and it can be deduced into whatever action or solution needs to be whatever solution is needed. And so with that being said, some of the research initiatives that I have started to work on is that, especially in loom of the pandemic and seeing the impact it does have on, women in particular, Black and racialized and Indigenous women, is that, I've been intentional to have calls to action in every space and place that I have the opportunity to speak at, to say these are some things that you can do, not only to be an ally, but to be a co-conspirator, to advocate for those voices that ideally do not have a voice at the table. And the other piece is, I think my internet is lagging. I hope that it's still capturing. But we're good. Okay, thank you. The other piece, the other part of my research initiative is that it's about the intentionality of disseminating my content, not just to the members of our community so they can be effective advocates for themselves. So my interrelatedness power framework, I share that with the community through a lens of, this is how you advocate and navigate through a system that's not designed for you. And some of those underpinnings came from, the works of the Black Panther Party movement, where, when the system wasn't working for them, they decided to create a system for themselves. And as a byproduct, during the Jim Crow era, the institution, i.e. the government, didn't like it. So that's why you saw all these other things that came into play to make it look like these people were gangbangers or people that were looking to cause harm. But in hindsight, all they were doing was trying to advocate and bring learning to the community, breakfast programs to the community, disability rights to the community. And so taking a page out of that book, My Interrelatedness Power does that for the community. But the other part of that is going to leadership and saying, as an architect of influence, your decisions impact the lived experience of the members of the community. So this is why it's important for us to have people that look like me or look like those that you're serving at the table. When you're developing policies, it is important for you to collaborate and have discourse with those that these policies are going to impact. When you're doing research, making sure that your sample size is reflective of the sample that you are trying to support, serve, or identify. And so having that model, they're able to see what exactly I'm talking about, but more importantly, they can see how their decisions as an architect of influence does have an impact on those on the receiving end, not just the person, but not only the community, but we're talking at the micro level, the emotional, the mental, the physical, and the spiritual. And I find that part actually has been quite effective. And I'm grateful that one person at best, when they saw what I was talking about, they couldn't unsee it. And because they couldn't unsee it, now they have to start thinking differently of how their decisions are impacting those directly and indirectly.
Thank you so much for that response. I think it's really speaking to the importance of having these conversations. As you said, once you hear it or see it, it's hard to unhear it or unsee it. And you touched on many important pieces, of course, inclusion, whether we're talking about services, really starting from that planning stage onwards, research, etc. And you also brought up the importance, I think it's really um, significant to highlight of history and looking at the history of, for example, medical harm against different communities, including Black communities, of course, and how that could also be impacting their interactions with different service providers and the trust there as well. And yes, I really encourage everyone, whether in many different areas, there's linguistic research, there's research on pain perception in the Black community. There's even racial biases in the perception of Black people's facial expressions in terms of misinterpretation of emotions like anger, happiness, and how that has led to a lot of harms and sometimes even, deadly harm when we're thinking about police violence. So a lot of amazing research to go through. Thank you so much for sharing your perspective, Dr. Garvey. And I'll pass it over to, on my screen, it's Sabrina.
Yes, thank you so much. So I think my answer to this question is highlighting what Dr. Garvey just kind of went through, but I agree that one of the biggest barriers I see in women's health today, and particularly in perinatal health, because that's mostly what I focus on, is that persistent gap between clinical care and the social and structural determinants that shape pregnancy risk long before someone even enters a hospital or sees a provider. And I think that we often talk about pregnancy complications as medical events, but so many of these outcomes are really deeply rooted in conditions that exist completely outside of that clinical encounter. And so I guess the first issue that really stands out to me is that unequal access to prenatal and preventative care. So, like both Jacqueline and Dr. Garvey were speaking about, I think marginalized communities, whether it be because of income, race, immigration status, or even geographic isolation in Canada, they will often access care later in their pregnancy with fewer touch points with the healthcare system. And I think that these are really missed opportunities because a lot of adverse pregnancy outcomes can be completely prevented or mitigated with timely screening and intervention. So that's the first major issue I see. The second one, and I think this is more of like epidemiological issue, is fragmented data systems, like we were all of the panelists were kind of speaking to. I think, clinicians rarely have access to social or environmental information that could inform risk. And our systems in Canada really were not designed to integrate data on income, stress, environmental determinants, neighborhood deprivation, for example, alongside those important clinical indicators. And so what that means is that clinical decision making is often just completely relying on this incomplete picture. And if we're using, data driven tools and risk prediction tools that only incorporate these clinical determinants, we can inadvertently reinforce those inequities by, creating these tools that are only performing for the people who have the most contact with the healthcare system. So those are the two main issues that I see. And my hope as a PhD student is that I can kind of contribute to building these tools that are not only more accurate because they incorporate all these different determinants, but also fairer because, again, they're incorporating the lived realities of individuals across Canada.
Thank you so much, Sabrina. And again, we're hearing how this, solely medical view when we're thinking about health is insufficient in general, but especially when we're thinking about marginalized groups such as women and then those with multiple marginalized identities as well. So thank you so much for your work. And I do look forward to those tools being updated. So I'll pass it over to Jack.
Well, thank you. And I'll just kind of echo and kind of extend on some of what Dr. Garvey and Sabrina have talked about with regards to this, because I really do think that when we look at improving cardiovascular health for women, we really need to improve our health surveillance systems. So that's been a big call to action from the Heart and Stroke Foundation, as well as the Lancet Commission to improve or reduce the burden for women by 2030. So we really can't change what we do not measure. And with these different types of fractured systems, I think we really have to think about right now leveraging relationships with different interest holders and partners to find out, one, what can we measure and what can we measure well right now to be able to start understanding the impact of our different programs on diverse populations. And then what systems can we use to integrate the different census data to understand different financial barriers? So some of what I'm doing as well in Manitoba, in particular, we have hybrid funding for cardiac rehabilitation, which means if you don't necessarily have insurance, you are going to have to pay about $300 to access cardiac rehabilitation. And there isn't a lot known about different systems to get people to access maybe subsidy programs. So that's a huge hit for us or for anyone to pay uh, out of the blue. So I'm trying to look at different ways in which we can share with the different cardiac rehabilitation centers and Manitoba policyholders that financial barriers potentially exist and start finding ways in which we can measure when we create an intervention that it actually worked, because our systems are so fragmented that it's hard to tell even if something does work. I also kind of have this caution that maybe other panelists maybe feel as well. I do fear the onset of a little bit of the AI and kind of weapons of math destruction as they were, because that's from another book. But yeah, when we think about how we create these different algorithms and different things, they're based on who the samples are driven from. And these are primarily not diverse samples, and they do reinforce the barriers and the predictions that have already occurred. The other thing I think that's important to think about as we move forward to enhance or reduce some of these structural inequities is to include patient partners and include people with lived experience throughout the research process and in making the change. So I'm very lucky to be involved with the Canadian Women's Heart Health Alliance that includes clinicians, trainees, caregivers, as well as people with lived and living experience in addressing these problems, because a lot of the different research questions we think are important as researchers, the people living with the disease don't really care about, and that's a bit of a problem. So we need to identify different types of patient-reported outcomes like quality of life. How are we impacting quality of life, as well as how are we potentially how are people experiencing the intervention? So from cardiac rehabilitation, women aren't going, but we haven't really captured a lot of the patient experience measures to say, would you recommend this? Why wouldn't you recommend this? So that we can look at making changes that would make a benefit.
Yeah, Dr. Garvey, feel free to jump in. And in general, feel free to comment on one that is.
Yeah. No, so Jacqueline touched on such a critical point, and I really want to take the time to speak to that, and that's the AI piece. I had the privilege to work with the NGO CHW with the United Nations to help develop a framework surrounding gender bias and AI and the impact it does have on women in particular. And what we found in the research when we're doing this project, to Jacqueline's point, was that even within the AI, there's so much bias that lives and breeds within this infrastructure that we found on a global scale that it impacted the distribution of employment. It impacted what gender, like the gender-based violence literally morphed into something completely unfathomable, in the genesis of us doing this work, for my mind to wrap my head around of what that looks like in the AI space, especially when it came to online harassment and how that was being navigated, with regards to what is the rights of a woman going to look like with AI being interwoven into the various healthcare narratives and practices that are being explored within our healthcare system. And, what is the policy landscape going to look like incorporating AI into a policy that do impact women or those identifying as women? And so the recommendation that came out of the work was that in creating this model with the research team looking at how how are we going to govern AI through the lens of a woman. How are we going to make sure that even uh, in these spaces, these digital spaces, what is equity going to look like, and how are we going to make sure that our networks within our various communities are bridging those gaps, especially the digital divide, because when you're thinking of on a global scale, we're thinking about those that have access to now the digital space and place versus those that don't have access. What is working infrastructure going to look like, and how is the data, because our main concern in this narrative is data and how it's being poorly collected, or the data is reflective of a sample size that doesn't look anything like us. And now we're going to compound that with AI. So what is the data ethical narrative going to look like? How is education for us going to look like? Because depending on where you are in the world, education is still a barrier. Now we're going to compound that with the narrative of AI. What is AI education going to look like? How is that going to be integrated, especially when we're still navigating these barriers as women? Even access the fundamental right of to learn. And what are our rights going to look like? How are our rights going to morph or change based on this AI narrative, especially like I said, and I emphasize that the bias that lives within this narrative. So these are things I think even as researchers we have to think about. So it's not, even though we're here talking about healthcare, again, there's so many various intersections that even though that impact the lived experience of the woman. And so, what are we going to do through the education lens? What are we going to do through, policy lens? What are we going to do through legal lens? What are we going to do through all these various lenses? Because at the end of the day, it's still going to impact the individual, and it's going to impact the mental, the emotional, the physical, and the spiritual being of that person. So how do we navigate these spaces? So even though, yeah, we're focusing on health, there's so many other compounding narratives that do impact all that we're speaking about. So I don't want to ignore that piece. So Jacqueline, thank you for, bringing that point to the foresight, because I think it's so critical.
Any other thoughts about AI or in general from the panel speakers before we move on? Yeah, I think we'll be having more and more conversations about AI, not in this panel necessarily, but as time goes on, even when we think about gender-based violence, like was mentioned by the panel speakers, and sexual image-based violence, for example. So there's a lot more ethical issues that are coming up. Um, and yeah, so I'm sure there'll be many more opportunities for this conversation. So the third question is, looking ahead, what areas of women's health do you believe future researchers or clinicians should prioritize? Where do you think the most urgent or impactful work still needs to be done? And I'll also paste this into the chat.
Yes. I guess Sabrina. Okay. I think I'll maybe jump in on this one. I think looking ahead, it's really important for everybody to kind of learn a little bit more about sex, gender, and that intersectionality that everyone's touching on, about how our well-being and health is shaped by more things than just these clinical measurements at one time point, that how our biology, how society treats us, how our gender, race, socioeconomic status, disability status, sexual orientation, all those different things impact if we go seek care, the stress we hold that might be increase our risk for disease, and kind of how it impacts our diagnosis. The other thing I really think is we need to increase awareness of people, especially for women, with regards to cardiovascular disease, because it's a leading cause of death of women. And we need to see that awareness increase from not just the public standpoint, but also from healthcare providers, because it's still a huge lens that heart disease is a man's disease. One of the things that I think is really important is to tell everyone that around you that you love, and we want a lot of he for she to tell men about women's heart risk, the different factors, and that although women often report chest pain as the main factor, they may experience other symptoms along the way, such as the anxiety, jaw pain, shoulder pain, extreme nausea or fatigue that they'd never experienced, that sometimes cloud the picture for when they go to the emergency, that people start taking different diagnostic tracks rather than heart disease. I think it's really important across all different lenses is for women to be empowered to be a health advocate, to feel confident to speak up for what is wrong. I tell all women that if you think it's your heart, you know it's your body, say that first and try and find ways to get support and bring someone with you to hear and experience the event with you, because it increases power and it helps you maybe navigate challenging situations and have a witness to the experience if you can to support you. And I really do think that all this collaboration and working across groups to look at women's health across the lifespan is very important. And it's a real honor to be kind of in this panel to speak to this. And I'll stop there.
Thank you so much, Jacqueline. I think you've given everyone some tools that they can use, whether it's speaking up or becoming informed on women's health and cardiovascular health, that everyone can take away from this panel and apply within their own lives or work. So thank you.
Maybe I can go next. I started thinking about this actually when Dr. Garvey and Jacqueline, when you guys were speaking about the AI piece. I think, I mean, AI is not going away. We know it's sticking around. And so I think the first step, if we actually want to have these AI models again be fair and to reflect women, is that we need the data, right? We need data to train these AI models. And so I think as a first step is to actually integrate those social and environmental exposure data into women's health research, right? We've all been speaking about this throughout the panel, that the evidence is clear. Women's health is shaped by far more than these clinical factors. And despite this, they are rarely reflected in clinical data. And so these AI models that are becoming increasingly used in clinical practice are, of course, not reflective of women's experiences. So I think that future research needs to take that next step and treat the social and environmental exposures as core risk factors for perinatal, but also women's health in general. And I think without this, our tools and even our clinical guidelines are just going to be incomplete. And then, yeah, so I mean, once we have that data, hopefully that's not a faraway dream. Hopefully that happens soon. I think only then can we improve prediction and then prevention for high risk groups. Because, yeah, I think right now our system is just very reactive, right? We often are only detecting complications after symptoms appear. So after a woman actually shows up to the ER, like you were mentioning, Dr. Garvey. So at that point, options for prevention are really limited. So I think that if we can identify who is at elevated risk much earlier, ideally, like if we're thinking about pregnancy in the first trimester or even preconception, only then can we really prevent these adverse outcomes from happening.
Thank you so much, Sabrina. You're really, so, sorry. I just
No,
want to
no,
say
no, go for it, Roshan.
I was going to transition, but I wanted to just highlight how you're really speaking about prevention, how so much can be done in that prevention piece rather than just waiting for something to happen and then responding. And also, I wanted to point out how important it is to understand that AI is not flawless. Like I think a lot of people think, as far as I've heard. So people really take AI as fact, but it is not flawless, and there's a lot that needs to change. And I appreciate those ideas you brought forward, Sabrina, about that as well. So please, Dr. Garvey.
Yes, so several things. I love all what Sabrina and Jacqueline has said. And just to build on that, Jacqueline, when you were speaking, you were talking about cardiovascular health. And I'm like, yes, so important. There's not enough data surrounding that. And to compound that, mental health is health. So and a lot of our health issues literally start in our mind. So, if we are in a place of constant anxiety, constant stress, then that leads to then the cardiac piece. So I think a lot of times we forget that, for your body to function, your mental and emotional health has to be in a good place. And if it doesn't, then it leads to the cardiac issue. It leads to the diabetes potentially. It leads to potentially having cancer, any immunological disorder. And, there's so much evidence to validate how the mental health and physical health are one. And if you neglect one, then it impacts the other. And so, that is like one of our call to actions. Like we need to show that in the, not only through, the bodies of knowledge that exist, but show it through other narratives of evidences. And the other piece, to Sabrina's point with regards to, AI is not going anywhere, and we know that. So where are those, those data points? Where are those, where can we get that data set to incorporate into AI? And I think that goes back to part of one of those points I said earlier, like the bias. It's there because AI was created by someone, and that creation also came through a biased lens. And so, while it will not be perfect, I think that the constant narrative, especially through since emancipation, is that those that are Black, racialized, and Indigenous, they're the ones that tend to be the one that have the greater impact when we do this transitioning, because there's minimal data. So, think about it like this, for our listeners, is that we have limited data for women. That's compounded when you're looking now at data for Black women or racialized women or Indigenous women. Then now our sample size significantly gets sparse, almost non-existent. And that in itself is a problem. So how are we then going to make sure AI is not going to be biased when we have little to nothing to go off of? So it's so important that we consider that. And I think the other piece is that the intentionality that look for the minutia, meaning look for those those members of the community that their voice is not a part of any narrative, and how do we make sure that voice is included not only through the research but at the table. Meet them where they're at, find out what their needs are. I love that we are in a space that we love to do research, and we engage in what we're interested in, but sometimes what we're interested in may not have the impact factor we're necessarily looking for the communities that we're serving. So as we're engaging in research and we're looking at various projects to engage in, it's always important to circle back to the community that is going to have the greatest impact and say, we're looking to do this project. Is this something that will benefit the community? And if the answer is no, then what is it that you need? And that's even for myself as a Black woman. Even before I engaged in doing this current grant that I'm working on, I went back to the community first, saying, this is what I'm thinking about doing. What are your thoughts? Yes or no? And if I do this, what are those things that need to be in my proposal before doing the application? So even though I belong to that community, I do recognize that I'm in a place of position. I know my positionality. I'm in a place of privilege. And so their lived experience may not necessarily be the same as mine, even though we come from the same cultural group. So I literally went, strapped on my boots and went back to the community and say, hey, this is what I'm thinking about doing. What do you think about this? And they gave their voice. So this project is not just the project that I'm working on. This is a project reflective of what the community asked for. And I think that's very important, because sometimes we do forget that piece. Anything that we do in research, we still need to go back to the community. And Jacqueline had her hand up.
Oh, I was just speaking to something that Dr. Garvey, you kind of sparked when you were talking about the mental aspect of thing. And if we're thinking about moving forward, especially with cardiovascular health, we kind of forget that the heart and the brain are connected by a bunch of blood vessels. So there is a new huge thing moving, and I'm glad you brought that up to talk about the brain-body connection and brain-body axis. And another major thing impacting all women that we go through and takes about 7 years sometimes on average, that's really not very well supported, that I think is deserving of a lot of recognition, is kind of the menopausal transition and learning more about hormone replacement therapy and how that can impact or improve our health moving forward. And I really like that Dr. Garvey really talked again about always going back to community and finding about what the answers or what's important. I can even speak to my own experience with patient partners. We develop infographics together and I send out the messages, we work together, and then I send it back to them and I want to hear what they think of it. I drew this, what I thought was a great roadway or pathway leading back home, and they send it back and say, it looks like we're falling down the sewer in the drain. So I was like, well, I'm so glad that we work with the patient to identify these different things. And it's very powerful because there's so much in nuance that we miss sometimes when we're just stuck in our own head and our own research. So going back and remembering why we do this and who we do this is so important.
Thank you so much for all of that. And I think, again, everyone can definitely leave this session with a lot to think about in different ways of thinking, whether that's in general or within service and research. So thank you all for that. I want to see if there's any questions. Uh, would that be in the chat?
Within our Q&A, it's not a question. Oh, wait, sorry, there's a question at the end. My
Oh, okay.
apologies. It starts out saying, thank you to all panelists for sharing your work and stories with us. It's been a very powerful session. If there is time, this question is for any of the panelists. What future do you hope to see for the next generation?
That's a loaded question. I think I'm going to try tackling it. What do I see for the next generation? I think it's what I see for the next generation is like going back to basics, having a safe space. And what I mean by that is that a young woman can go to her clinician, or a young woman can go to an educator, or a young woman can go to an architect of influence and say, I am navigating X, Y, and Z. I need your support without getting the pushback, being ignored, being traumatized, being triggered, being dismissed as if their concerns are not legitimate to their lived experience. I know that's a very simple answer, but it goes back to, all of us in this space have purpose. All of us in this space have a destiny and a calling. And part of, and when you understand that, really and truly, it's for us to bring community together. It's about uniting one another, empowering one another, educating one another. So, if we are effective in our destiny's calling and our purpose, then the future should be very promising because we're walking in an alignment of what our objectives are, which is to support those that are marginalized, those that are ostracized, those that are racialized, the immigrants, those that ideally do not have a voice. And in this space and place, because we are in a place of privilege, we are able to give them that voice that ideally that would have never happened. So it's bringing community together and understanding the individual and the community collective.
Wonderful, thank you. No other questions have come through. Just a reminder, if you have a question, to pop it in the Q&A box located in the navigation bar at the bottom of your screen.
I guess I'll maybe speak a little bit more because Dr. Garvey did an amazing job of kind of answering that and tackling that question. And that's kind of, I feel similar in that I'd really like the future to look more at shared decision making, where there are conversations back and forth between the clinician and the person with the lived and living experience to identify the best path forward for them in their situation. The other thing that I really hope that healthcare and other people do as a clinical exercise physiologist in the community and throughout is to think more about this concept, and I only more recently learned about it, is kind of social prescribing. A lot of different things that we do could just connect people to groups to give them power, to give them voice, to give them connection to improve their health. So a lot of what I do sometimes working with seniors is to identify like these different community programs that are free, that they can access to feel like they're connected to the community, to feel like they're making a difference, to do more. And I really hope that that happens with the future, that we connect more back to care.
Maybe I'll just add to that, Lyndon, if there's no other questions right now, because I totally agree with both Jacqueline and Dr. Garvey. And I personally hope for the next generation is exactly what you were talking about, Jacqueline, is this kind of shift towards more integrated models of care. So approaches that kind of recognize that, like we've all been talking about, women's health doesn't occur in isolation from a person's social, historical, or cultural context. So something that I've seen that's pretty remarkable in the perinatal context are more culturally specific models of community-based care. So things like Indigenous midwifery programs have really shown a lot of success in improving trust and outcomes. Even, trauma informed perinatal care that kind of acknowledges how past trauma can kind of shape engagement with the healthcare system. I think a lot of those models of care are kind of coming forward, and I hope that that's what will be prominent for the next generation.
Thank you. There was one more question that was put in the chat, actually. So the question is, how do we engage men in these discussions, and do we need to?
I was muted. Yes, we do need to include men in these discussions. Uh, and the reason why is because they take up a lot of space. And when they do engage in research specific to us, they're looking at it through a very different lens. And they're looking at it through a lens which they don't have a lived experience to. So it's very important for them to be in spaces like this, for them to not only understand the lived experience, but then to engage in a discourse that ideally doesn't necessarily happen. Being a part of various projects, a lot of times, and this is not a male woman thing or a man thing, is that if you are the primary investigator, you just come to your own conclusions of what you want to do, how you want to do, what it's going to look like, what is your methodology, what is your inclusion, what is your exclusion, and there's no discourse necessarily with the other members of of your project. So that said, I think both Sabrina and Jacqueline said it has to be a shared approach. It has to be a approach where that grace and humility must be a part of it, meaning put that ego aside, put what you believe to know to be true, and listen to those that you're looking to engage with, of how to formulate your body of work, or how to navigate, or reframe an assessment tool, or look at how we're going to start having discussions. Because the reality is, as long as we are here and breathing, we are learning. And so we don't know everything. And we may know a lot about one area, like Sabrina knows a lot about, prenatal health. Jacqueline knows a lot about cardiac health. I know a lot about mental health, but I don't know everything, and neither does Jacqueline or Sabrina. So I think we need to have, again, that's our positionality. We need to understand what our position is and how we are going to navigate the space. And from a man's lens, that's why they need to be here, because what do they know about women and women's health?
And I guess just to extend that, I completely agree. And I think we need men and greater collaboration. Like they talk about he for she, to talk about engaging them in the research process, engaging them in the dissemination, engaging them in these engagement or awareness campaigns because the people around them, 50% of the people around them potentially are women. So we want to keep these people around, sisters, wives, uh, daughters, all these different people are impacted by this. So shaping the conversation around the people they love and helping to improve their health and outcome, I think might be an important thing. But across the board, I do think data sharing, like Dr. Garvey kind of just highlighted, I know a lot about one thing. Everyone else knows a lot about other things. I think we need to come together more to answer these complex questions with data sharing and not keep all our data in silos and start to make data management plans where we can kind of share what I'm working on that has some sort of mental health aspect, which we're working on that you could answer way better than I could with more complex methods. And I think that that's a really important thing too, how we can kind of move all of it forward.
I'm just going to say quickly, interdisciplinary, right? That's really what it is.
That's the word I blanked on.
Great. Okay. There aren't any more questions, so I think we can wrap up. Do our panelists have anything further they'd like to add? Rusan, would you have anything you'd like to add?
No, I think it was a great conversation. So thank you all for being here. I really enjoyed this discussion.
Thanks so
Okay.
much for having me.
I echo the sentiments. Thank you
Yes.
so much for having me and allowing us to have this space to have real conversation.
Yes. No, thank you all for this. This was very engaging and enlightening across all disciplines.
Great. Well, I'd really like to thank Rusan, Sabrina, Crystal, and Jacqueline for being here today on behalf of the HEI EDIIR Working Group and the Department of Health Research, Evidence, and Impact. It was lovely to have everyone here for such a great discussion. I've put up on the screen here a few additional resources that our panelists have passed along. We will have this available after the panel if anybody would like to have access to these resources. Additionally, I would just like to share um, the Canadian Institutes of Health Research, Sex and Gender in Health Research. These are some resources that you can access by the QR code here if you'd like to learn more. So again, just thank you to everybody. This was such a great session.